But what we don't want is that that impacts long-term on your health. So we want young people to achieve their health, educational, social and financial potential if at all possible. In paediatric services, the child is always first and foremost, so the child is at the centre of everything. But what happens when you're a child is that lots and lots of people tell you what to do. So by the end of your time as a child with ALD, there's input from many, many different professionals, and you're sort of down there at the background of it all, with lots of people telling you what to do. And what we try and do through the process of transition is that we bring the adolescent to the fore, so that they begin making some decisions, they begin getting involved in their own care, and they get to choose other people that might help them make decisions that are not necessarily those parents and professionals that have been around them for many years. Why are adult services different? It's because we're trying to focus on independent living. So we're trying to move from parental, doctor, carer control towards patient control of their lives. We discuss issues that you might not necessarily discuss in a paediatric clinic: alcohol, smoking, drugs, sex, etc. We discuss how ALD, AMN might impact on your life in future. So how do you get life insurance? How do you get a mortgage? Can you have a driving license? What's going to happen with your further education? What support is available to you? Can you get personal independence payments, disability allowances? How is this going to impact on employment? What do you tell your employer? And again, we've heard a very good talk this morning about fertility, pregnancy and inheritance, and that's a very important part of adult services. So the difference really between paediatric and adult clinics is that in the paediatric clinic you're very much focusing on the whole family. Children are very rarely seen alone in clinic. Parents make most of the decisions. It's quite prescriptive, so we think you should do this. If you as a parent opt to do something completely off the wall, you might end up in trouble with social services. And it's very nurturing. Again, the child is very much at the centre of the whole thing. As an adult, it's the patient first. So once you hit 16, and certainly once you hit 18, it's you, and you get to make most choices. Most often, we would prefer to see young adults alone, not necessarily at the first appointment, because we do recognise the value of having parents there, but we like to move towards that the young person would come and see us alone. There can be issues that young people will like to talk about, and often this will relate around fertility and sexual experience, etc., that they don't necessarily want mum and dad in the room. And it's more collaborative, so you get to discuss together what you would like to do. So it's not necessarily, we think you need a bone marrow transplant, we think you need this medication. It's working together and deciding for you as an individual what you think would be best. So you have a lot more power as an adult to choose your therapies. When should this all start? So as young as possible, I think, is the answer to that. There are lots and lots and lots of different studies. I've just shown a couple here. But really this could start, from 10 onwards. So you start preparing young people for their more independent adult lifestyle. And this is one model where, under the age of 3 you receive care, but from the age of 3 onwards you should be participating in your care. So that might be as simple as little Johnny hopping up in a chair to get his hydrocortisone from the cupboard every morning, under your supervision, and you're checking that he's taking it, but he's got a role in going and getting the hydrocortisone from the cupboard, and it's something that he does. And that the amount of role that he takes in his care increases year on year. So by 11, Johnny should come down the stairs in the morning ready to go to school, and the first thing he does is he goes to the cupboard himself, gets his hydrocortisone and takes it. And ideally, you're not nagging him. Very idealistic, but that's what we should be aiming for. And then by 15 or 16, essentially, hopefully many young people, if they have the capability, will be looking after most of their own care. There are very different perspectives with chronic disease that you get from parents and from the child who has the disease. And we don't often think about this. We tend to see everybody in the clinic together. We ask a question, somebody gives an answer. It could be the child, it could be the parent. We don't often take you aside separately and ask you the same question and see what you say. But this quite nice study looked at 303 young adolescents with arthritis and separately gave them a questionnaire, them and their parents, and then compared the answers as to how their chronic condition, how their arthritis impacted on their daily life. And found that in 50% of cases, parents were either underestimating or overestimating the impact of their condition on their life. So, only the individual with the disease really understands how they feel with that disease, and sometimes it's quite hard for us to remember that. So I've James, sitting in the third row there, has recently taken over, I suppose, from Dr. Ashok Volodi at Great Ormond Street Children's Hospital, and has been doing a review of the service over the last 30 years, just looking at the number of young people who have come through that service. So these are all boys, I think, that you're talking about here. So over the last 30 years at Great Ormond Street, they've seen 29 boys with an ABCD1 mutation, so it's not actually an enormous number. The median age of diagnosis was 7 years, just over 7 years. This is the pathway that the children at Great Ormond Street would follow, or the ideal pathway. So once the diagnosis was made, it would be checked to see if they had adrenal failure. They would have an MRI, and depending on whether or not the MRI was positive, that would determine whether monitoring continues every 6 months up until the age of 12, and then annually after that. And obviously, if there were changes on the MRI, then consideration would be given to transplant. So these are the numbers of the 29 boys who've been seen there. 18 developed cerebral ALD over their time, and 11 have continued monitoring but haven't developed cerebral ALD. Of the 18 who developed cerebral ALD, 5 had early ALD at diagnosis, and those 5 all got a transplant, and 3 had ALD picked up as part of the monitoring program, and again, they've all had a transplant. 9 young boys, unfortunately, had very advanced disease at diagnosis and were not deemed suitable for transplant. And then looking at our own numbers in the adult services, so I've just looked back over the last 8 years. That's how far back our electronic records go, although we have paper records going back a lot further. So in the last 8 years, we've seen 104 individuals with an ABCD1 mutation, 55 of them female, 49 of them male, so almost 50-50. Of those, 27 are currently asymptomatic, so don't have any symptoms from their disease. As you might expect, the majority of people who don't have symptoms are female, just a small number of males without symptoms. 1 male has adrenal insufficiency only. We also have no females with overt adrenal insufficiency, although like the Dutch, as you will know, most of the women here, we don't routinely test everyone, but we've certainly not had any female with an Addisonian crisis. And any females that we have tested have had normal short synectin tests. Then we have a large cohort of adults with just AMN. So we have 17 males who've got symptoms of AMN but don't have adrenal failure, and 31 females who have symptoms of AMN but don't have adrenal failure. We've got 11 males who have both AMN and adrenal insufficiency, and we have 17 males from that cohort of 104 who've had adrenal leukodystrophy. So what's happened to the 17 males? Well, 4 of them have had a transplant. All of those were men who had a transplant under the age of 10 years. So the majority of those are Great Ormond Street, but I think 1 has come from Bristol and is now living in London. 5 have unfortunately died with ALD, so have presented at either later in adulthood. So 3 of these were men over the age of 50. And were not suitable for transplant, and others who presented at a younger age but unfortunately presented late on with cerebral ALD and were not and died with the condition. We have 2 patients at the moment who are under consideration, adults under consideration for possible transplant. And then we have 6 other individuals who've got, we heard earlier about some individuals who can have an episode of cerebral inflammation which then stabilizes out. So we have a number of individuals who have lived for quite some time with stable, either reasonably mild or in some cases very severe disease and progressive disease. So what's our aim for this service? So we've been reviewing things with James, and the aim really is that there should be a smooth transfer, a smooth transition from the paediatric services at Great Ormond Street Hospital, either to ourselves or indeed, if it's more geographically appropriate, to another adult centre in the country. How we plan to do this is, for some time now, we've had a joint transition programme with Great Ormond Street Metabolic Service, where we run joint clinics, and either Robin or myself will go across 4 times a year, and we'll meet families and their children in the paediatric services. So we're going to extend that now to include ALD in that service. The paediatrician will send us a very comprehensive summary letter. So we will get the whole natural history of the condition, we will get the mutation, we will see what the post-transplant follow-up has been, etc. So hopefully we will be able to keep that smooth and have a record throughout life of what's happened to individuals and maintain the natural history. And we will organise in the adult services endocrine and post-transplant follow-up as required. The strengths, hopefully, of this will be that we already have shared metabolic laboratory facilities. So, for example, all very long-chain fatty acid levels, whether for the adult service or the paediatric service, are done in the same laboratory, so they can be directly compared. Robin and I have joint contracts across Great Ormond Street and the adult services, so we can move between hospitals, we can see results in the children's services. We have a joint weekly meeting where we meet with James, both laboratory-based and also teaching-based. And because we're in the National Hospital for Neurology, although neither of us are neurologists, we're metabolic doctors, we have rather a large selection of neurologists on site, as well as some very good neurophysiotherapy. And neurophysiotherapy is not available in many places. You get standard physiotherapy, you know, if you've broken a bone or whatever, but not necessarily neurophysiotherapy. So that's certainly a strength. There are weaknesses. One of the first of which is that there's very limited experience among adult haematologists of following up this type of patient or individuals with ALD in their post-transplant clinics. They're used to following up people who've had transplant for malignancy, so they get a little bit thrown when we produce somebody who's had transplant for a metabolic condition. But that will change with time as they see more individuals coming through. Getting access, and I probably don't need to tell you all of this, getting access to the supportive therapies such as physiotherapy and occupational therapy in adult services is a lot more difficult than in paediatric services. You get little courses, so you can have 6 weeks of physiotherapy, or you can see the occupational therapist once or twice a year, but it's very difficult to get that in an ongoing way, and that is a weakness. There is no easy transition pathway for social, educational or employment needs, and many of you have been through that process where you lose your social worker at 18, you lose your educational package at 23, you have to fill in 100 forms, it takes 2 years to get through the process, you have to fight, you have to appeal. It is very unfortunate and very difficult, and I think that's where ALD Life can be very helpful, and you know, helping each other in the room with that form filling process is very difficult. At the moment, and I put this in brackets because I don't know whether we should be doing this or not, in paediatric services there is a move to identify ideally a matched sibling donor for transplant. We don't currently do this in adult services because we haven't up until recently really been considering transplant for many people, but perhaps that is something we should think about. It is much more difficult, as we heard earlier. So if you are the index adult case in your family, so let's say you're a male aged 35, diagnosed with AMN, you're the first person in your family. You then end up with the responsibility of telling your siblings that they might be carrying this condition, telling your parents that they might have passed it on to you, talking to your partner about the fact that you might have passed it on to the children that you've already had. It's a really difficult position to be in. Getting a matched, as you get older, and again we heard earlier, it's much more difficult to be a donor, and so if you are an older index case, it's likely that your siblings will also be older and they're not necessarily going to be a suitable donor for you. You might not even talk to your siblings. They might be living in a different country. So this is not as easy in childhood to identify a donor within your siblings. So what we do, or what we will be doing if we haven't already done it, is for all new patients, most important, genetic confirmation. So it is still not that unusual for someone to come to us without having the condition confirmed genetically. So that will be the first thing that we will do. Hopefully we will discuss the condition with prognosis and management with you. We sometimes forget that we need to do that with young men who come across at 16 and 18, because of course those discussions have been had with their parents when they were 3, 4, 5, 6 years of age, and we forget that we need to do that again, almost from scratch with young men. We do need to discuss inheritance and what's available, and again we had a great talk this morning about that. An important point which didn't really come out from the talk this morning, that if you are a man with a mutation, you also have the right in the UK to approach fertility services and say, I do not want to pass this on to my daughters, and you have the right to ask for funding so that you can also have fertility treatment to avoid that situation. And we have had a number of men who've been funded for that. And then the role of family screening. I've discussed how difficult it is if you're the adult male and then you then have to approach the other members of your family, or even an adult female, you have to approach other members of your family and tell them about this condition, and that's difficult. So for men, if you've recently come across to us and you've either been monitored in childhood or you've had a transplant and you're still being monitored, what you should expect is regular examination, looking for signs of AMN and other issues. An annual brain MRI, certainly if you've not already had a transplant, with or without a neurocognitive assessment, if there are any concerns. Regular short synaptin tests, again, if you're being monitored and you're asymptomatic, and other bloods. If you've had a transplant, you might say, well, why do I need to go to the adult clinic? What's the point? I've had my treatment, I don't need to come. And we've already heard a little bit about the fact that we don't have so much long-term data, and there's a little bit of suggestion that even if you've had a transplant, we may need to still look out for AMN at a later time. There are also post-transplant complications that not everybody will have, but again, they need to be monitored and checked for, so it's important to come to clinic for that. And we can underestimate, I think, the psychological effects to a young adult of having had a transplant and having spent an enormous amount of time in hospital as a young child, and how that, as they come through adolescence, they will understand more what that is about and what it might mean for them in the long term. And so there may be support needed for that. If you've been diagnosed with AMN rather than ALD, or haven't come through the childhood program but you presented for the first time as an adult, then we will do a short selection test on diagnosis, and maybe for a few years thereafter. What most of us have found is that once AMN is established, if you haven't got adrenal failure, then you don't tend to go on and develop it with time. So it tends to come either before or around the same time as AMN, but after a few years with established AMN, we don't see that much adrenal failure. You will probably have a neurophysiotherapy referral. We'll talk about orthotics, functional electrical stimulation, whether or not you need a wheelchair, etc. And then really important, so I'm very glad you pointed out about the urologists. For adults, neurourology is really important, and for many of you, that will be one of your overriding symptoms, problems with bladder, bowel, erectile dysfunction, etc. So referral to appropriate specialists. And again, annual brain MRI if we're talking about transplant for adults. For women, much of it is the same, so again, neurophysiotherapy referral, and we know now that many women have bladder and bowel symptoms, so hopefully they would also be seen by specialists if needed. I thought I would show you, I don't know, is anyone wearing FES? Excellent, so you might get to model that later. Let me see if I can get my video to work. This might not, no, hang on. I'm going to talk hopefully while the video is running. Yes, okay. So, functional electrical stimulation, for anybody who hasn't seen it, is electrical stimulation via the surface electrodes. So this is the device down the bottom. You wear the little pack on your waist or your belt, and then the others are connected to muscles and nerves on your lower leg. This man does not have AMN. He's now walking without his FES, so this is his normal gait. I didn't have a video of someone with AMN, so we'll have to get someone to volunteer later. So this is how he walks normally. And now he's going to walk back with FES on one leg turned on. So it's been turned on his left leg. So what you see is his foot clearance is much better and he's able to walk quicker. And in a minute he's going to turn round and they're going to turn on both legs. So he'll have his FES on both legs on. And again, you can see how much freer his leg swing is and how much better the front of his foot is lifting off the ground. And now he's decided, I don't need that stick at all. Now, this is not a miracle cure. It's very important to point out. This man does not have AMN. FES does not work for everyone. You need to be walking, so it will not work for anyone who's in a wheelchair. You need to have some good muscle strength left in your legs. So people earlier on in the disease, it can work for some. And quite a few of our patients have tried it and don't like it. So it does have a quite slightly unusual sensation, but it certainly is one of the options for treatment that's available in adult centres. We've talked about bladder and bowel, so just quickly to show you, we did about half of our patients returned a survey a couple of years ago asking about their bladder and bowel involvement. And effectively 100% of men who returned the survey said they had bladder and bowel involvement, and about 80% of women. So it is really significant part of the disease, and there are a lot of very good treatments available for that. So it's definitely worth coming to clinic to talk about those. So final slide. As well as all the medical bits, there's lots of other support. There are, what's the term? There are more than one support organisation, but obviously the best one is ALD Life. We haven't talked at all today about the psychology involved in this condition, and I know you have other workshops where that's going to be dealt with and how you cope with the diagnosis, but that's really important, and most good centres will have access to a clinical psychologist, and we have one, as does Great Ormond Street, and also psychiatrists if needed. You can also refer yourself, so there's a big government initiative, and so this website, IAPT, is Improving Access to Psychological Therapies, and you can go into that, put in your address, it will tell you what's available for you locally. Some patients need their specialist and dietitian support, and the HFEA that is the website about fertility. It will tell you where the nearest centre to you doing PGD and counselling for fertility, etc. Thank you.